So I'd like to thank Anne and the committee for inviting me to speak. It's great to actually be here in person because I must admit over the last 6 months I've got completely zoomed out. And the title I was given is, if serology is the answer, what's the question? So I reckoned at this stage of the afternoon you'd have heard lots about the background to the virus. So I won't reiterate what's been said. The only extra bit of information for this talk to think about is, as you all know, the spike protein is on the outside. This is an enveloped virus, and the nucleocapsid protein, which is a common target for serology assays, is actually within the cell within the virus predominantly. The other thing to think about before we get into assays and what they mean is to think about the biology of the immune response to the virus. It's worth bearing in mind that we do not use serology for diagnostic purposes in any other respiratory virus. And there are pretty good reasons for that. So this is one of many studies which show the timeline over which people develop antibodies, measured in this case by a pretty sensitive ELISA technique. Sorry, now my x-axis has been hidden, but by the end of the first week, only 60% of patients with a highly sensitive assay will have produced any detectable antibody, be it IgG or IgM. And by day 14, approximately 90% will have developed antibody. This rises again, so by the time you get to 21 days, most people will have made antibody. But this virus is highly infectious with very high viral loads in the pre-symptomatic and early days. So using a test that has very limited sensitivity at the time when you're most infectious is going to lead us in trouble. So as we were all very fed up, thinking what a terrible time we were having in March and April, and antibody tests came on the scene, everyone said to me, antibody tests will be the answer. And the three most common questions I was asked were, can't we use antibody tests to diagnose infection? And in my clinical lead role, I'd become quite involved in procurement of PCR equipment and reagents. And everyone thought this would be brilliant because there was millions being spent on PCR equipment, and should the antibody tests be much cheaper? The next question was, well, can we use antibody tests to tell us when patients aren't infectious anymore? And sure, once you have an antibody, couldn't we let people out of isolation and stop wearing PPE? And worryingly, that sometimes came from microbiologists. And the surgeon's favorite question was, won't an antibody test tell me that I'm immune? And then I can stop with this PPE carry-on. So if we think of a very simplistic outline of COVID infection, when you're exposed and infected, you have an incubation period, which is asymptomatic. You then have a symptomatic phase. There's an asymptomatic phase during which viral shedding can sometimes, but not always, still be occurring. And eventually, hopefully, people will get to clinical and virological recovery. PCR tests may be positive anything up to a week before the onset of symptomatic phase, but certainly in 2 to 3 days pre-onset of symptoms. They're positive throughout the symptomatic phase, and we now know that they can remain positive for many weeks. And in fact, that's quite a problem because people can continue to be PCR positive for weeks and months. As I've shown you, antibody tests take 14 to 21 days to become positive. So they actually become positive really often beyond the symptomatic phase. So they are more useful at telling you that you had COVID rather than that you have it. So bear in mind, antibody tests will usually be negative in early infection when you're at your most infectious. And even when antibodies become positive, you may still have significant viral loads and may still be infectious. So that's unfortunately a no to the first two questions. But the surgeons were still, every time they met me in the corridor, arm out, will you check my antibodies? So people, I think, particularly at the beginning, were taking a very simplistic approach to antibodies. All antibodies are good antibodies. All antibodies will tell me I'm bulletproof. And we have to think about the biology of antibodies. If, as Luke mentioned, they bind to spike and are neutralizing and prevent the virus binding to ACE2, those are good, potentially protective, neutralizing antibodies. But there is a phenomenon whereby suboptimal antibodies can actually make an infection worse. And this is a real concern for vaccine design. And there have been some spectacular vaccine failures where the antibodies produced were non-neutralizing. And instead of stopping infection, they allowed the virus to enter other cells by the back door because the antibody, which hasn't neutralized, binds to an Fc receptor and brings the virus in a particular way. And when that happens to macrophages, you can get massive inflammation. It's a big concern in vaccine design, but it can also contribute to the pathophysiology of some infections. So not all antibodies are the same, either in the lab or in vivo. Antibodies play a limited role in antiviral immunity. One of the key players, as soon as you become infected, in protecting you against infection is interferons. So when the virus enters your cell, any nucleated cell can produce alpha and beta interferons. That has a paracrine effect on neighboring cells, leads to induction of antiviral proteins, and makes neighboring cells resistant to spread of the virus. And we know that one of the things that SARS-CoV-2 does is inhibit interferon and interferon pathways. And so potentially one of the reasons that we see such high viral loads is because one of the tricks the virus has is to inhibit our first line of defense. As well as interferons, natural killer cells will kill off infected cells, so they're part of our rapid response force. Antibodies, as well as T cells, play a role in adaptive immunity. But as you can see, the antibody response is one of a multi-layered army of defense against SARS-CoV-2. And as Luke has already mentioned, in some of the other high-impact coronaviruses, even when antibodies no longer detectable, robust T-cell responses may keep us safe. We've done quite a lot of work in collaboration with colleagues in Galway in getting together panels of pre-pandemic sera and patients who are mildly affected by SARS-CoV-2 and patients who've been hospitalized. I don't have time to go through it in detail, but the purpose was to really look at sensitivity and specificity of diagnostic assays. But one interesting observation, and it is in line with some other published data, is that the production of anti-spike antibodies, shown here, sorry, I'll stop pointing at things. So the anti-spike is on the x-axis, and that's measured by the VIDAS assay, and anti-nucleic capsid on the y-assay, and there's really no correlation. And of particular note, there are dots absolutely sitting on the x-axis where there's no anti-nucleic capsid antibody, but really quite high amounts of anti-spike. And conversely, there are patients that are negative for anti-spike antibody who produced anti-nucleic capsid antibody. So in this population of over 120 positive patients, while there were people who were negative for anti-spike or negative for anti-nucleic capsid, when you combine the assays, everyone in fact did make some antibody. So with a combination of assays with 100% sensitivity, we can detect prior infection. So back to the surgeon's questions. Will an antibody tell me whether I'm immune? As we said, not all antibodies are protective. We need neutralizing antibody. And remember, we need it at the site of infection. So neutralizing antibody in your blood is no good at stopping virus in your throat. Stick to the nasopharyngeal epithelium. Reinfection has been reported, including in a small number of patients who are antibody positive. There is a big study ongoing in the UK called the Siren study, where healthcare workers were screened for antibodies, and those who consented are being swabbed and tested every month to see if they do become reinfected, even in a mild asymptomatic way. Remember, antibodies are one component of a complex system. I think it's very informative to look at our patients with immunodeficiencies because we learn so much about human immunology from this group. It's really interesting that we worried at the start so much about the hypogamma patients. We got 90 patients out on home therapy to avoid the hospital. But actually, the data has shown that patients with Bruton's agammaglobulinemia, so no B cells and very little antibody, totally dependent on antibody replacement, even when they get COVID, do remarkably well with lower mortality than the general population. So that would suggest that B cells aren't essential, or B cells and antibody aren't essential for protection. And in fact, some people seem to do better without anti-COVID antibodies. Very interestingly, in the last month, there have been 2 papers back-to-back from a wide international collaboration showing that people of even mild defects in production of interferon do particularly badly with COVID. And they described 2 groups. There were patients who had genetic defects in their ability to produce interferon or in the interferon signaling pathways. And then the second paper describes an older adult cohort who had developed autoantibodies to interferons. And we have some of these patients with autoantibodies to interferons who, to be honest, they're not desperately unwell. We would have investigated them because of recurrent and sometimes nasty cold sores or herpetic lesions. But they're not people who are severely ill or they're out living a normal life with bothersome but not serious infections. But unfortunately, in this paper published in Nature, the patients with antibodies to interferons do particularly badly. The cohort that are a real worry are patients with T-cell defects, either iatrogenic defects due to treatment. So 25% of patients who've been transplanted in the UK this year who got COVID have died. Similarly, there's very high mortality in people post-chemotherapy and some of the hematological malignancy patients. So the answer to the question of will the antibody tell you whether or not you're immune? Not really. Lacking antibodies doesn't bother the Bruton's patients, and actually it's interference with T cells and interferon seems to be far more troublesome. So the next question then was, well, are these assays good for anything? And that's the current question they keep asking. It's important to say not all assays are the same. We need high specificity assays, but at least when we use high specificity assays, we know that these, when positive, will indicate previous infection. I think routine clinical use is somewhat limited, but there are enormous research values of trying to understand how this pandemic has spread, how prevalent it has been, and potential association with complications. The main clinical reason we would be asked to do a test or to do an urgent test is where there's concern about a post-infectious complication. Probably the most widely described, but not the most common, is pediatric inflammatory multisystem syndrome, which is a Kawasaki-like syndrome and a fairly devastating disorder in children. As Niamh has described, there's no doubt there are thrombotic complications, and very reasonably, when you have an apparently unprovoked thrombosis in somebody who has a history of a COVID-compatible illness a few weeks prior, we do get requests for antibodies. As yet, to the best of my knowledge, although I'd be interested in Niamh's comments on this, there's no difference in how that patient's thrombosis will be managed. But there may be differences in the future, and I think correctly classifying patients is at the time of their illness is important. There's a huge concern about lung fibrosis and post-infectious fibrotic lung disease post-COVID, but also how COVID infection will impact on pre-existing lung fibrosis. So really, COVID serology is becoming part of the workup for apparent interstitial pulmonary fibrosis. And as we've heard, some people run quite a chronic course with a very nasty and disabling post-viral syndrome. In some of those patients, there's been a clear diagnosis and antibodies don't add to that. But particularly in March, April, May, when swabbing capacity was quite constrained, the bar was set quite high for people to actually get a swab in the community. And so in some of these people who now are faced with chronic ill health, it can be of interest to establish if they had COVID, or in fact, if the illness may have been flu or something more mundane. The other aspect of demonstrating that somebody has had COVID is also in some patients who are incredibly anxious about what COVID would do for them. So obviously, as an immunologist, I have a number of patients who would be at high risk, who are absolutely terrified that they will die if they contract this virus, and yet describe symptoms that may well mean they've had it. The reassurance when you can tell somebody, do you know what, you have had COVID. That doesn't mean you can't be reinfected, but you've had it and you've done okay. And if you're reinfected, almost certainly it will be an even less severe event. Seroprevalence studies have added and will continue to add to our understanding of this condition, and that in turn will inform public health measures, both for the general population and on a more targeted basis. As you know, the SCOPI report, which is a study to investigate COVID in people living in Ireland, has been completed. This showed that 3.1% of participants from Dublin were positive, only 0.6% of participants from Sligo were positive. So Dublin and Sligo were chosen as a high and low prevalence population. And from that, the statisticians estimated that the national prevalence of COVID infection was 1.7%. And at the time when this was done in August, that was threefold higher than the number of people who had been diagnosed by PCR. Of note, this study, as well as taking the blood, used an adaptation of a WHO questionnaire about COVID-compatible symptoms. And 75% of the people who were antibody positive had symptoms compatible with COVID-19. We're now doing a study to follow up the patients who are found to be antibody positive to look at the durability of those antibodies and see how long they remain detectable. The PRECISE study, which is looking at the prevalence of COVID-19 antibodies in the Irish healthcare workers, has commenced in James's and in Galway. And I understand here in Tala quite extensive work has been done looking at seroprevalence in the Tala healthcare workers. And I think the more information we can get and the more we can pool and analyse that data, the more informed we'll be about how to protect our colleagues in all aspects of healthcare. Because certainly our experience in Beaumont has been that it's not the people who are working on the COVID wards who are getting infected. Most of our outbreaks have been either in non-COVID wards or places like the lab. So, you know, we really need to understand better what is happening. The other area of interest in relation to antibodies relates to passive immunotherapy. Now, many of you will be familiar with this, where you have a patient who has had the infection, who then recovers, and post-recovery they have blood drawn if they have high titer neutralizing antibodies. There are a number of companies producing hyperimmune globulin, which can then be used either for prophylaxis or for treatment. This is, I suppose, a bridge to getting monoclonal treatment. And of course, as anyone who loves the President of the United States, or even doesn't, will be aware, there are such monoclonals available and in trials, and now Trump is going to make them available for free for everyone in the States, which means there'll be none left over for any of the rest of us. So passive immunotherapy from donated plasma is usually only a bridge until you get a monoclonal. One of the interesting things in relation to attempts at passive immunotherapy is ideally you want to get high titer neutralizing antiviral antibodies without a lot of anti-HLA antibodies. Because if you give people plasma with a lot of anti-HLA antibodies, the risks of TRALI, of lung injury associated with the transfusion, are increased. And in some of the work that has been done, it's been shown that post-COVID, there's a very high instance of anti-HLA antibodies. That has slowed down the efforts to prepare convalescent plasma therapy, and from my point of view is potentially a real problem for patients on transplant waiting lists, where if they get COVID, they are at risk of making anti-HLA antibodies, which will make them harder to transplant. So to summarize, we've learned a lot about anti-COVID antibodies, but there's still lots to learn. We know they're not helpful and not recommended for diagnosing active infection. We know you can't use antibody assays to establish clearance or that you can de-isolate a patient. We know that the presence of antibody does not indicate long-lasting immunity. And just a note that not all antibodies are equal. They can be helpful in establishing the diagnosis in post-infectious complications. They are the basis for seroprevalence studies, both national and targeted, and play a role in selecting donors for convalescent plasma studies. They are important in showing that vaccines are immunogenic, although the presence of antibodies doesn't mean they will be protective. And there is a potential role to allow you focused surveillance on people who are seronegative with no history of COVID, although that is still somewhat controversial. So I'd just like to acknowledge the people who did the antibody work. Anne Clooney, Laura and Karina in our lab did the Beaumont and all the Roche work. And our colleagues, Owen DeBarra, Ellen Sweeney and Paul Reedy were the ID team who collected recruited patients and collected the samples. And Una Nurian with Joanne and Maria in Galway did the VIDAS, and they also did Abbott assays, as well as wading through their freezers for pre-pandemic sera. Thank you very much.